From anatomy to anesthesiology, from pathology to pharmacology, from microbiology to medicine, a one-man resource to the world of health sciences. Welcome to Dr. Paul's Medical Lectures. A practicing physician, Dr. Paul offers you essential insights on diseases afflicting millions of people around the world. For today's lecture, here is Dr. Paul.
Good evening, folks. This is Dr. Paul. Thank you very much for tuning to our channel this evening. Today I want to talk a few minutes about Paget's disease, a very, very important disease because we see these patients regularly. Paget's disease is a chronic disorder with enlarged and misshapen bones. And there is excessive formation of the bone and the bony tissue. And the affected bones, over the time, they get weakened and bowed out, and they cause fractures, they cause arthritis and the pain in the affected bones. So it's a localized bone penetrating disease, but it can happen all over the body or the skeletal system. The pathological process is initiated by overactive osteoclastic activity, followed by osteoblastic activity. So osteoclastic activity resulting in the resorption of the bone is followed by osteoblastic activity forming the new bone. But the problem is this whole thing causes a mosaic of woven and lamellar bone, and it's a mess because in the process of resorption and the formation of new bone, there will be misshapes, there will be excessive bone formation at wrong places, and the patients get arthritis and fractures secondary to expansion of the bone, and sometimes even important tissues like nervous tissue gets compressed by this bony growth. So there is a first of all, let's see about the patient population. This disease is high. This has a high prevalence in Western Europe, the countries like Great Britain, France, and Germany, but you not see this in Switzerland or Scandinavian countries. And also you see this disease in European immigrants to countries like South Africa, New Zealand, and North America and South America. And it's not seen in indigenous like native people in Asia, native people in Africa, native people in America. So this disease has some connection with European ancestry. So most often you see Paget's disease in people who have a European connection, no matter where they live, whether they live in New Zealand or South Africa or North America, South America, it doesn't matter. If they have European connection, they have a risk for this disease. Now, what is the etiology? The etiology of Paget's disease it's still unknown, but there is evidence to suggest there is some genetic and viral connection. So there is a genetic connection because 15 to 20% of people have a family member having this disease, and it is common in first-degree relatives. And there is also a clear genetic basis running in familial bone disorders with this problem. So there is genetic connection and there is also a viral connection. So the genetic connection, there is a homozygous deletion of the TNFR SF gene. So that is the gene, you don't have to remember that, but that is the gene deletion we see in this disorder. And it is a control, this gene like TNFR SF11B gene, that gene has a connection with these patients. Another interesting thing is there is some viral connection. People with Paget's disease, we have evidence today showing viral infection contributing to the clinical manifestations of this disease because there is presence of cytoplasmic and nuclear inclusions resulting paramyxoviruses like measles and respiratory syncytial virus. These are paramyxoviruses. So they are growing in Pagetic cells, but we could not culture live virus from these Pagetic bones. That's why it is not a clearly established connection. So genetic connection, viral connection. Now let us see the pathophysiology. Basically, there is the increased number and activity of osteoclasts. So the principal pathology in Paget's disease is the increased number and activity of osteoclasts. Pagetic osteoclasts are like, they are large because they are doing a lot of work, and they have almost 100 nuclei. You see, regular osteoclasts have like just 5 nuclei, but these cells have like 100 nuclei because they are working so hard and they become big as they are absorbing so much bone. So they eat away a lot of bone. I mean, usually we see regular osteoclasts eating away like 1 microgram per day, but these osteoclasts, they eat away like 9 micrograms per day. So there is 9 times more resorptive activity done by osteoclasts in Paget's disease. So there is this osteoclastic activity is going on. Then comes osteoblastic activity. And what happens? Because of the increased absorption by osteoclasts, and there is increased bone formation. And this goes in 3 phases: osteoclastic phase, osteoblastic phase, and the burnt out phase. So the first phase is osteoclastic phase, second is osteoblastic phase, third is burnt out phase. And many times they happen at the same time. And if you see in osteoclastic activity, you will see the lytic lesions. There is a name for this, blade of grass lesion. So the blade of grass lesion is seen in first phase, that is the osteoclastic phase, where there is lot of bony resorption and hypervascularity in the bone. Then comes the second phase. In the second phase, osteoblasts are working. As you know, osteoblasts, they form the bone. But the sad thing is, it's not like an osteoclast making a mess, then osteoblasts going and clearing it up. It's a chaos, like osteoclasts are working here and osteoblasts are working here. There is no synchronous activity here. So imagine somebody is building something, somebody is destroying something. If somebody is destroying something and somebody is building the same thing, then there is no problem. But if somebody is destroying here and somebody is building here, the building collapses because there is no plan. So the same thing is happening here, folks. There is no plan. Osteoblasts and osteoclasts are acting erratically, destroying the strength of the bone. And as a result, the patient suffers from multiple skeletal problems. Now let us see the most important bones: pelvis, vertebral bodies, skull, femur, and tibia. Those are the things most commonly involved skeletal sites: pelvis, vertebral bodies, skull, femur, and tibia. So you can actually imagine what kind of symptoms they are going to have based on the most common sites. The most common presenting symptom is pain, because what is happening here, there is a lot of bony vascularity, there is lytic lesions, and as a result, bones may become weak and bowed out, creating pressure on the ligaments and muscles that are attached to these bones and causing pain in those muscles. And patient may be having a fracture because of the weakened bones, and that causes pain. So the most important, the most common, most frequent symptom is pain. So the patients come with pain, and many times this disease is just asymptomatic, but whenever it comes to your presence, the pain symptoms will be important, and you can guess where the pain is happening. If it involves the head, it will be a headache. If it involves the back, it will be back pain. If it involves pelvis, it's a hip pain. If it involves the tibia, it is like some knee pain. So based on the area that is involved here, patient gets different kinds of pains, and sometimes even neuropathic pain, because when Paget's disease involves the skeletal system like spinal cord, it can cause that compression of the nervous system, resulting in pain. So let us say when the head is involved, that increased bone can actually put lot of pressure. That's called frontal bossing. This frontal bossing, sometimes they act on the cochlear nerve in the inner ear and cause even hearing loss in these patients. Sometimes at the base of the skull, it's called platybasia. And when it involves the base of the skull, it can actually cause brainstem herniation, and patient can go into coma. So now let us see a case. A patient came to you and he says that he's not enjoying his evening walks anymore because he's having pains in his legs and his gait got disturbed. He cannot wear his old hats anymore because they are too small to fit his head. And what is your diagnosis? Remember, he said one thing: he cannot wear his old hats because they are not fitting his head anymore. That's an important clue. He said he cannot walk and enjoy because he's having pain in his legs. So there is increased head activity, and he also said there is a decreased hearing. What is your diagnosis? Paget's disease, because the head became big, the hats are not fitting off. He has decreased hearing because cochlear nerve damage is happening because of that bony activity. He has leg pains because osteoblastic fractures are happening, or probably the bones actually bent out. So you see, folks, you can actually really think through this pathology based on the symptoms of the patient. And fractures are a very, very common complications in these patients, especially in long bones. Because long bones like tibia are involved, patient will have a leg fracture. And also these patients are prone for neoplasms. Neoplasms, they can arise in these pagetic bones, and majority of tumors that happen on pagetic bones are osteosarcomas. Remember that, they are osteosarcomas. So if a patient has a long history of Paget's disease, he has a risk for developing osteosarcoma in these problem. And there is also these osteoclasts, they are going erratically. They can also form giant cell tumors. So you need to treat these patients with glucocorticoids. The another important complication I want to talk about is cardiovascular complications are happening like up to 35% of these patients. You see, there is a lot of alkaline phosphatase being released because of this bony activity. And also because of the osteoclastic activity, there is so much vascularity, like bones get hypervascularity and the heart is pumping the blood. So there is too much pumping and pumping and pumping. The heart becomes enlarged. There is like a cardiomegaly because of this. And there is too much of heart pumping that results in high output heart failure. Let's do a case. A 50-year-old patient came and he says that he has a history of shortness of breath and chest pains and he's getting fatigued, and you ask him his past medical history. He says he's having some joint pains, otherwise there is no past medical history. So he says recently he developed shortness of breath and chest pains, and for the last 5-6 months he has joint pains. And you did a physical examination. In your physical examination, you heard a grade 3 systolic murmur at aortic area. And you examined his legs and you saw like some bowing of legs. And you examined his skull. You saw some kyphosis in the skull. What is your diagnosis? Just think through how the patient is presenting here. The patient is having shortness of breath, chest pains on one side. On the other side, in your physical exam, you found out his legs are bowed out and his spine has kyphosis. And in your auscultation, you found out a grade 3 systolic murmur at the aortic area. So, analyze both problems. What are you saying? On one side, you are saying a heart failure. You could hear a systolic murmur, and the patient has symptoms suggestive of heart failure, like shortness of breath and chest pains. So, patient has heart failure. And where is this heart failure coming from? Patient has bowed legs, patient has kyphosis, probably patient has Paget's disease. And asymptomatic Paget's disease, I mean, he has joint pains, So it's not actually asymptomatic. I should say it is undiagnosed Paget's disease. So he has joint pains coming from Paget's disease, and he has developed kyphosis. Probably Paget's disease is there in his spine. He is developing those burning of legs because of the osteoclastic activity in tibia on both sides. So it fits to Paget's disease, but the disease was not diagnosed. His original problem, the Paget's disease, did not bring him to the doctor, but he developed heart failure because of Paget's disease, because of those all erratic osteoclastic cells causing hypervascularity, and that hypervascularity causing arteriovenous shunting, and the heart is pumping and pumping and pumping so much blood, and heart went into a high output heart failure. So you see, folks, there is undiagnosed Paget's disease here causing high output heart failure. But that high output heart failure brought the patient to the doctor, not the Paget's disease. You see how uniquely this patient has the problem. How uniquely this patient has got this Paget's disease. He does not even know he has Paget's disease. That's not what took him to the doctor. But over the years, he developed high output heart failure. That's what took him to the doctor. So you say this disease, folks, can happen in so many ways, and I have seen a few patients in different settings. So in the next video, I will talk about diagnosis and treatment. Please follow with me with that. And that's about Paget's disease. Thank you very much.
Thanks for listening. For more medical videos, please visit us at www.drpaul.org and take time to browse through hundreds of health videos we regularly post on our site. If you are preparing for USMLE, PLAB, and other medical exams, make sure you visit our website to browse through our videos explaining the essential points you need to know before taking these examinations. For more information, visit us at www.drpaul.org. Thank you, and may God richly bless you.